You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. Evelyn Gallego, CEO of EMI Advisors and Program Manager of the SIREN HL7 Gravity project, joins The Dish on Health IT to talk about the critical standards and vocabulary work being done on social determinants of health. This work aims to make SDoH data more fluid to better support not only patient care, but human services. We hope you find today's episode helpful and that you'll share your topic ideas with us by emailing us at podcast@pocp.com.
Hello, everyone, and welcome to The Dish on Health IT, where we break down and discuss some of Health IT's biggest news and most exciting milestones. We at Point of Care Partners are Health IT consultants. We work across all stakeholder groups: payers, healthcare delivery entities, pharma, Health IT vendors, health information exchanges, and government agencies. And we're viewed as an independent, trusted party, the Switzerland of consultancy. I'm Ken Kleinberg, practice lead for innovative technologies, and I'm excited to be your host for our many new episodes here in 2021, where we feature Point of Care Partner experts as well as special industry guests. Now, on to today's podcast. My co-hosts from Point of Care Partners, Jocelyn, Keegan, and Pooja, Babbrah, and I are especially excited to welcome today's special guest, Evelyn Gallego, founder and CEO of EMI Advisors and program manager for the Social Determinants of Health-focused SIREN HL7 Gravity project, one of the most successful fire accelerators. Among the key topics we'll be asking Ms. Gallego about are why are we seeing so much interest in social determinants of health today? The background, governance, and funding of this Gravity project, some of the more IT-related details in terms of fire APIs, implementation guides, pilots and testing, and finally, how it all relates to government policy and the larger forces of value-based care and consumerism. But before we jump into our discussion, I'd like to have my co-hosts briefly introduce themselves and what excites them about today's podcast. So Jocelyn, could you please go first?
Hi, I'm Jocelyn Keegan. I'm our payer practice lead here at Point of Care Partners. I've been with POCP for about 4 years, and I spend time really in the mashup of where strategy and technology come together. I'm the program manager for DaVinci. I'll talk about that in a minute and why I'm excited about having Evelyn here with us today. And in addition to that, I spend time really around prior authorization and where payer and provider collaboration really mashes up. So why I'm excited to have Evelyn here, we started talking about the idea of doing an accelerator around social determinants of health, I don't know, probably 2.5 years ago now at a HL7 meeting. Evelyn and a few other colleagues that we're close with were just sort of gleaning the experience of what it took to get DaVinci off the ground. And there isn't a more competent person to help steer this topic or this issue, as you'll get to hear from Evelyn today. And I personally think, when we look at all of the wiring and the work that we're doing to bring together and free data from a payer, provider, sort of industry perspective, if we can't get at really sort of these kernels around how the topics and the challenges around social determinants of health mash up with how we can get people adherent and into the therapies that they really need, we're not going to get the outcomes and sort of the human impact that we expect to get out of all these technology investments that we're making. So I'm excited to hear about the progress that Evelyn's making and have a good discussion about sort of how this aligns with all the other work that's happening in the industry.
Thanks, Jocelyn. Pooja, how about you?
Yeah, hi everyone. Pooja Babbrah, and I'm actually the PBM practice lead for Point of Care Partners. I've been with Point of Care Partners for about 6.5 years now, and my focus is really on kind of the strategy consulting. So I work a lot with clients, helping them kind of understand what's happening in the industry. This past year or so, a lot of focus has been just around price transparency, pharmacy transactions, kind of everything related to those kinds of topics. And I'm actually really excited to have Evelyn on because we had a project a couple years years ago now where we talked to payers, and one of the questions we asked them was, what are you doing around social determinants of health? And the answer at the time was really, we know we have to do something, we just don't know what yet. So to see kind of the progress that has been made and kind of everyone now and you'll hear about this, I'm sure, from Evelyn, just, the number of folks that are at the table now talking about this, folks that are stepping up to do pilots. It's really amazing to see kind of that change from when the payers were saying, yes, we need to do something, we don't know what, to now people lining up to actually do something, and all the work that's being done through the Gravity project around, standards and vocab and all of that. So really excited to have Evelyn here to talk about that and dig into kind of what's happening now a couple years after we heard that from the payers. So great to have you here, Evelyn.
Okay, great. Well, now let's greet our guest, Evelyn Gallego. Welcome to the Dish on Health IT. Thanks for taking some time to talk to us. How about we start with having you more fully introduce yourself? Tell us a bit about your background, especially your time with ONC, with HL7, your work with HIMSS, your deep federal consulting background in health and social services, and how that led into you becoming a leader in social determinants of health.
Wow. Thank you, Ken. And thank you, Jocelyn and Pooja. I'm so excited to be here today to speak to all of you. So I am the CEO and founder of EMI Advisors. We are a certified small business administration 8A consulting firm located out of the Washington, D.C. area. Our work is primarily with the federal government, working on data interoperability and business transformation initiatives. I started EMI 6 years ago with the goal of really helping my clients connect or bridge the gap between health IT policy and standards and business requirements. Much of my work in health IT builds from my initial work supporting the Office of the National Coordinator over 10 years ago. I came in as an independent to help launch several high-tech initiatives, beginning with the state HIE program. I then moved on to support the ONC standards and interoperability framework, which led me to the creation of the care planning standards. So I worked with ONC in developing the volunteering criterion for the care planning that was proposed under 2014 CERT and then included in the 2015 CERT. Also worked on launching the Structured Data Capture Initiative, where we introduced using FHIR. So it was exciting because my evolution into FHIR and standards builds from the projects that I supported with ONC. So, it's grown, but I know we'll talk about Gravity after. So
Yeah. Before we get too deep here, just to ensure our listeners have a more solid foundation for today's discussion, could you provide just some basics about social determinants of health?
So for those not familiar with the definition, SDoH, or social determinants of health, is defined by the World Health Organization as the conditions in which we are born and live that affect our overall health and quality of life. We have growing evidence that over 50% of our overall health is driven by socioeconomic factors and the physical environment. In the last 5 years, so I would say even before I was introduced to SIREN, we did have this growing interest from health industry stakeholders around addressing SDoH in clinical settings. And this comes from this growing body of evidence around SDoH information improving whole person care and lowering cost. Of course, this is a focal point in the shift to value-based care, value-based payments, where more healthcare organizations are increasingly being pressured to produce better outcomes and more value for dollars spent. So, of course, we also know that unmet social needs negatively impact health outcomes even before COVID. The U.S. already experienced growing racial and ethnic disparities in health outcomes. COVID has only further exacerbated these disparities as the data continues to show that the virus disproportionately impacts people of color. I know I wanted to get my facts right. So the CDC just recently published that 48.7% of COVID deaths from May to August of last year were of people of color. So hence, there is a strong value proposition for collecting and using social risk data because of these growing disparities that we're seeing right now, even in the administration of COVID vaccines. But we also don't only need to collect this data to improve clinical care, the delivery of care. We need it for social risk interventions. We need it for population health management, for risk adjustment, for community health improvement, and of course, for research, the cycle of the learning health system. But again, even with the business case made clear, clinical systems, primarily those that capture and document data, including EHRs, have not been able to consistently and effectively address social needs because of this existing challenge on how to document the data.
Yeah, that's those are some compelling reasons to advance here. So thanks for that background. Could we now dive into Gravity?
Sure. So the Gravity project, we kicked it off in May of 2019 with the goal of developing consensus-based standards to support the interoperable data exchange of SDoH across health and human services systems. So the standards support what we say agreed upon language, right, for SDoH data concepts. So, that's as Jocelyn alluded to, we initially we're just focused on the code. So we wanted to be able to support the data definitions and then the coding gaps, and then work with HL7 to develop the FHIR standards. So from a funding perspective, we started Gravity with funding from the Robert Wood Johnson Foundation that went to SIREN. We initially targeted the data definitions for 3 domains: food insecurity, housing and homelessness that come together, and transportation. We picked these 3 domains, or SIREN picked these 3 domains, because it was feedback from health systems that these were priority for them. They needed to do a better job in addressing interventions that were identified within these areas. But since then, we've completed those. We are now working on financial insecurity, education status, employment status, veteran status, social isolation, stress, and interpersonal violence. We're still working through all of them, but we have a multi-domain initiative. You ask our participants. So since we convened in May, we have had over 1,500 participants from the health and human services ecosystem, which is significant. As I mentioned, I've worked on standards initiatives for many, many years. I had never imagined that I would be able to convene such diverse stakeholder groups, but it was really important to be able to get buy-in from those organizations that felt they didn't have a seat at the table, right? So I think one of the success factors for us is that we did, reach out. We spoke to many individuals. We sort of explained the value proposition for them. Most of these groups had no idea what standards were, let alone who HL7 was. And they continue to view this work in this, they're more interested in establishing agreed upon language. So the users of the systems and the data understand each other. So for them, is like for community-based organizations, they just want to make sure if they're receiving a referral from the health system, that the health system has identified the social need correctly, right? So that they understand what they're saying. We say it's a language. It's very much semantics. They welcome, like I said, they welcome the opportunity to have a seat at the table. Many of them are wary of health systems. They also are very cautious about medicalizing SDoH. That's one of the challenges we face. So they want to be able to inform how we define these so we don't end up with those issues. Gravity then became, so RWJ funding was a small pot of money. And then because we had such robust interest, we knew it wasn't sustainable. We needed to raise money. And so that's where we shifted to look at more of what DaVinci was doing and how DaVinci was structured. So in August of 2019, we became an official FHIR accelerator. We started thinking through, so this also we'll talk about macuturopathy later, but it was really about how can we create a project or initiative that would incentivize different stakeholder groups to participate and sponsor in it, and not make it, was really important for SIREN to not make it a pay-to-play model. So we needed to have stakeholders that would never sponsor the project still be involved in decision-making. So we created this new governance structure. We have 3 committees. We have an executive committee, a strategic advisory committee, and a technical advisory committee. All of them represent 6 stakeholder groups, and including health plans, the federal government, we see patient consumer participation, community-based organization, providers. And so, we say 6 overarching stakeholder groups, and we really make sure that we have representation from all groups in all those three committees. So right now our funding is quite complex, I will say, but it supports our mission of making sure that we do meet the needs of our vast stakeholder groups. So right now we have model like DaVinci where we have sponsorship. Primarily it's overseen through HL7, different sponsorship tiers, mainly that it is the health plans and the health IT vendors that fund through that. Then we have, we say grant or foundations sponsorship, and then contracts. So to date, our largest sponsor is Think Health, previously known as NEHI, the Nebraska Health Information Initiative, that received funding. So it's CMS funding. So we'd say the federal government, because those funds, even though they're being channeled through the state of Nebraska, are Support Act-led funding. So, so it's federal. And then we have contracts from ONC. So it creates again, diverse. The other foundations, still funding comes through SIREN, but we have to be able to incorporate that. We are missing the large EHR vendors. So they are not coming to the table as we thought they would, even though this is really critical for them. And if we're included in USCDI, they probably would soon. But they're the ones that are missing.
All right. Well, we'll get into some of those details of technical IT details in a moment. Let's pull Jocelyn in. Jocelyn, you've had all this experience with the payer-provider DaVinci Accelerator. What are your views on what Evelyn just described with Gravity, and how do you see its importance?
Yeah, I think that so much of what Evelyn just described, I think is typical of any of this sort of multi-stakeholder work that we're doing in the industry, right? It's the right people with the right model, with the funds to do the actual work, right? Because at the end of the day, I think what we're seeing in the FHIR community is this ability to bring in enough resource to have focused work, right? Complemented by the many hands, right, that care about the work. And that light level of funding enables that work to get done faster, I think is incredibly important. But I think that the path that Gravity has taken, and sort of you heard Evelyn talk about from an evolution perspective, of really focusing on sort of the data and the terminology and the code sets first, is incredibly important, right? Because part of the challenge around this topic in particular is sort of all of the different ways people had used to describe it or sort of quantify this information. So coming up with a common vocabulary, right, for this side of the industry and for these, sort of inputs into healthcare is so incredibly important so that you can actually get this information into workflow, right? And so, I think we've all sort of started on these journeys to say sort of what comes before the next thing. I think the challenge and the learnings that Evelyn's coming out of sort of this terminology work, I think is incredibly important for all of these collaborative efforts that are happening under FHIR. We haven't tackled those in a meaningful way. We're going to need to sort of sort out the 5 different terminology sets that people use sort of on the benefit side of the world. But I think the leadership and the models that Gravity is creating is incredibly important. And if we can't get these sort of parts of the workflow and this ability to get to all of the stakeholders, whether it be that person that's going to provide transportation or whether it's going to be a care team member that's out in the community actually getting somebody into service, then all of this work that we're doing to shift towards value-based care is it's not going to deliver the patient impact that we really want to see. Because I think that we can build out all the APIs that we want, but if we're not actually impacting and getting people to better care and better outcomes, then what's the point of all this investment in this work that we're doing? And so what I love about Gravity is it's really hands-on, really bringing together communities that have been incredibly dispersed, that are perpetually sort of underfunded, right? With people that have the funds and the resources to be able to do this work in the round. But it's not an easy work, and sort of making sure that all the stakeholders stay engaged and that you get everybody to the table at the same time is there's a little bit of I think a sisterhood of a brotherhood in the type of work that we're doing to really sort of continue to bring it over and over again the parties of the willing that want to be out there at the front making the impact and making the change happen sort of working together to keep, I like to say proverbially, the plate spinning or sort of the wheels rolling, because it's incredibly important work, but it's also driving the whole industry forward when we think about all those deep, individual endpoints where people get their care on a day-to-day basis.
So next question for you, Evelyn. We'll take this deeper dive into the more technical aspects of gravity and social determinants of health. Could you speak to the use and value of FHIR and interoperability here? We've talked a little bit about terminology. You've got an installation guide initiative. What's the progress there? What are you planning and looking for in terms of upcoming pilots and testing? And if you'd like to mention some of the challenges. If you're trying to connect to a food bank and they don't have an IT system, how do you manage that? How does the physician know that the patient visited the food bank? So please.
Sure, Dad, thank you. So just, I want to take a step back and just acknowledge that the Gravity project consists of 2 work streams. So that's, and thank you, Jocelyn, for highlighting the, terminology. So we have our terminology work stream, and then we have our technical work stream. And we started, as I mentioned, we started Gravity really to address the coding gaps in the market, right? The coding gaps that needed to be worked on. And that work is critical. So I appreciate, again, Jocelyn highlighting that. It's true. We couldn't get to FHIR if we didn't address the terminology work first. And so both work streams do function in parallel, but we say they interact at the center in the publication and use of value sets. So where FHIR plays a critical role, we say it supports both the representation of the data and the exchange and sharing of this data. So, I always think of FHIR standards like, vocabulary, terminology, and content and transport standards. You can create FHIR, resources and implementation guides that are expose data, move data from A to B, but you have to have agreed upon data definitions, right? So that's why they need to work hand in hand. Our FHIR work, we started it a year ago. So it came after we started terminology. And we just completed our first ballot, and we're in the process of ballot reconciliation. So we're a bit more streamlined than DaVinci. We have 3 use cases and only 1 FHIR IG, but the FHIR IG is focused on clinical care. So we do envision, and this is also a plug for future work, our current FHIR IG is scoped down to just the capture and exchange of data, like the capture of data within a clinical setting, a primary care office, a health system, and moving or exchanging that data downstream to community-based organizations. There's a lot of interest. The next on our pipeline, it's not in our roadmap right now because we haven't officially started it. We'll do public health. We also have strong interest in doing community-based to community-based data exchange. So not even interacting with the health system. And this happens right now all the time. So it's really, how can we employ FHIR for that? And we are funded right now by the Office of the National Coordinator under the HL7 Cooperative Agreement to investigate what are the standards being used by community-based organization? What's the data infrastructure that exists? And how can they be made FHIR compatible? I've voiced to ONC that, we're doing this as we are with our FHIR IG, it's clinically focused, but we don't know enough. Right? We don't know whether FHIR is the best applicable standard to exchange data in community-based organizations. So we'll be working on that. We have to do a framework for ONC. We also, so for you to ask about our other activities pilot. So I mentioned we have multi-stakeholders in our governance structure. We engage a lot with federal agencies. So the nice thing too, even though they don't directly, so I want to talk about the Administration of Community Living, ACL. They're one of the agencies under HHS. So ACL provides grants to states, agencies on aging. So it's really to support the elderly, services in the community for the elderly or developmentally disabled individuals. And they actually issued a challenge grant. So that's why we say it's also one of our success factors for Gravity is not only incorporation in policy and program, but grants. So ACL is an example where they issued a challenge grant for innovations in the market, and they made it a requirement of the grant that they adopt the Gravity standards. So that's a huge win for us because we have our pilots. So right now we're in phase 1 of the awards and I'm one of the judges. So we hope that through those solutions being proposed, we will have diversity of stakeholders. But again, a lot of those solutions proposed under the challenge grant don't bring in the electronic health records. They're really around supporting social care referrals. And to Pooja's comment, the ones I've seen, but I will take a look for pharmacy. I know I've worked a lot with the pharmacy on the pharmacist e-care plan work that does, they wanted to incorporate social needs in the care plan. And we are doing that through the multiple chronic conditions e-care plan project, which is not a Gravity project, but it builds off the standards work. So for that, the last part, I just wanted to acknowledge that even with the EHRs and the health information exchanges, community information exchanges we're working on, and what I'm seeing from the ACL challenge applications, we can't ignore the power of mobile technologies. So a lot of these is really about, you may not have an HIE in your local, you may not be connected. So how can we use mobile technologies to support referrals? So to your question, Ken, in regards to what do we do as we set these standards, we cite the example all the time that you can't have an electronic referral to a food bank, right? So you can have, you go through the intervention is, we want to refer the individual to the local food bank, but then the onus becomes on the individual themselves, right? Of being able to go. And the same would be for SNAP benefits. There's no connection right now where the clinical system can send a referral to the state's or local region SNAP benefits office. It's really saying to the individual, you go and apply. Here's the address, or here's the link. But we're saying, how can we use mobile technology so then that the individual can close the loop? So as an example, we say, how can we use, QR codes as an example that the individual scans at the food bank, and then it could go back to the clinical or the provider and saying, Jack actually went to the food bank, and it could rate it, and it could also give feedback, like perhaps, as right now, the food bank may not have enough food for everyone, right? But if there's a way to track that the individual actually went and did not receive, then there could be another way to identify where else they can, address their food insecurity.
Yeah. Pooja, Jocelyn, questions, comments?
I love this because I think that so often in our conversations around sort of how are we improving and how are we getting to that learning health system is this idea that everything sort of starts and finishes with the EHR and the patient record. And I think that, the work that we're doing in the FHIR community, and I think this point about it doesn't all end and start with FHIR. It's about what technology is available for the patient or the care provider or the, family member that's supporting that patient. Working to be in the hand or at the keyboard, right, that's going to be appropriate and the tool that's appropriate for that particular audience. I think it's important to call out, right, many of the things that Evelyn's talking about right now very quickly get us out of sort of the world of HIPAA and into the world of FTC, right, where this is patient-directed care and patient-driven services. And so this ability for us to take advantage of Smart on FHIR apps or just the app economy in general, I think is incredibly powerful to be able to really make sure that, just enough data flows and no more, right, about that particular patient, but how important that understanding existing workflows, making incremental progress on those workflows, understanding what data is critical and what data isn't critical at that particular point. And to Pooja and Evelyn's little dialogue, where are these endpoints in the community that we can really leverage and better enable with technology? But it's often not going to be, an expensive IT system. It's going to be sewing together the assets that exist or putting something in somebody's palm, right, or iPad that they can action and be able to, sort of connect people where they are in reality, right, in this digital, non-digital world that we live in. I am curious because I think when you talk about mobile, I think that's something that becomes really important here is this ability to be able to leverage just even existing technologies like direct and text messaging, secure text messaging. How do you pull groups like that into the conversation or different, sort of vendor solutions that are out there in the market?
Yeah, and I think that's what we're doing with this investigative work that ONC's funded through HL7 is really getting a sense of how can we use these other technologies, right? What is being used out there? And I know So we've had this even too with we look at 360X, right? The IHE profile that is direct and CCDA based, right? So we say, I do work closely with them as well. And we say, we can't, as a fire accelerator, we're not funded to look at updating CCDA, but we know it can, because that's why we say we specifically have the terminology and the technical, and we say the terminology standards can be incorporated in CCDA. Yeah. So the payload is whatever you use, and I want to acknowledge Lisa Nelson has done a tremendous job of outlining how to incorporate it within the document template. So I know it can be done. And she's demonstrated it as well. So I think that's what we're seeing, even when we're seeing in the ACL challenge applications, is they're looking at different standards that they can use. And really, I always say with CCDA and fire, I say, really, we have different types of roads, right? They, you connect, maybe one might be faster than the other, but it still allows the data to move from A to B. There's still structure in it. So it's really, but we have an on-ramp what to use.
Pooja?
It was a little bit kind of off topic, but, as Evelyn was talking about, especially the mobile, it just got me thinking, I wonder if there's, some international implementations we could be looking at. I mean, my mind immediately goes to, folks, being from India, the folks, they've got their carts on the street, yet they're able to transact with each other, right? They're able to share information with each other, and they don't even have smartphones, right? So immediately my head goes to where else could we be looking in, maybe in international countries, right, where they're doing some of these connections and using kind of existing rails that are already there, especially for some of these community-based. So I love the idea of the scanning the code or things like that, of, kind of thinking of how we can make sure we start sharing this information. Because the other thing is, how many of these, how many people actually go back to their doctor, right, and say, yes, I did use this service, and I do that myself. I often go and, maybe get some acupuncture or something. I never go back and report it to my primary care, but, just things like that are kind of thinking out of the box, which it didn't really even dawn on me until Evelyn started, kind of talking about these other ways to do this. So.
Yeah, well, this is carrying us into that more policy level discussion. And our new administration now, you mentioned Miki Tripathi is the new leader of ONC. That comment you made about not over-medicalizing social determinants of health, could you speak to that? And I'm thinking, if we're concerned about clinician burden, doesn't social determinants of health put even more pressure on clinicians to capture even more information? And, how does that match to what we're doing with COVID and so forth? So a lot to discuss here.
Yes, it's a continuous, it's an ongoing challenge. We see that even in our stakeholders, and the feedback is, so I'd say it's twofold. It's the burden on the provider to document this. We talk about the physician actually documenting the social risk or administering a social risk screening tool, right? They don't do that right now. They have their staff do it, but then they have to review it, and then they have to act upon that data, right? They have to identify the appropriate intervention. And if they're in a accountable care organization, they are then accountable for making sure that any intervention they assign, that that it's the right one to evaluate whether, it ended up improving the individual situation. But we also have the burden on the community-based organization. So one of the biggest topics that comes up, even in our strategic advisory committee, is CBO capacity. So even if we build the standards, we have the technologies, you have the health system doing the referral, the CBOs are not equipped to be able to start responding to all these referrals, right? So so there is a workforce, there's also an infrastructure, there needs to be more work done in that area. So you had asked about Miki Tripathi, lots of things. So with Miki, I think what I'm excited about him being at ONC is that he's really looked at this from the lens of the health information exchange, right? And data interoperability, working very closely with HL7. So I think he will understand that. I mean, he does understand the importance of being able to have the right infrastructure in place to support the capture and exchange of this data. and that it's not the same across the country, right? So, you have different models depending on where you're at. So how can we inform how these data infrastructures will be designed? So if it could be just mobile to mobile or Smart on Fire app data exchange, or if it's a health information exchange that provides other capabilities. So I think for us is just acknowledging that it's not going to be a one size fits all solution. We need to look at all the different technologies, standards, and being able to create the right infrastructure to support this data exchange.
All right. Well, let's see if we can address just a couple more questions. Do you see the states pursuing social determinants of health differently? And what about differences between, for example, commercial insurers or Medicare, Medicaid? I see that CMS recently described how they'd like to see better use of social determinants of health for Medicaid and CHIP.
Yes, so super excited about that CMS guidance. It's a pretty significant policy lever because it gives guidance to the states. It basically says, if you're drawing down federal match for your Medicaid programs, many of them too, they draw down federal match for their Medicaid information systems, right? So they're saying if you're doing that, but it's to support a social determinants of health program, you can, and they encourage them to use the standards defined in ONC's Interoperability Standards Advisory and those being developed by the Gravity project. So for us, this is, I would say from a Gravity project perspective, this is very significant. It allows, it's not changing. So unlike, it's not creating it's really, basically, it's not an additional burden to the states or to the providers. It's just saying, hey, if you're applying for, Medicaid funding, and you have social determinants of health, here, it's probably like you get brownie points if you acknowledge you're going to do a standards-based implementation. So I think there's lots of opportunity there. Of course, the other part is what the levers are at the state level. So we think of the different programs, right? So, CMS can have full authority over Medicare and has that through their conditions of participation and promoting interoperability, program requirements, and now the interoperability rule. But on the Medicaid side, it's really the states who have ownership, and CMS can only guide them on how they use their federal match. And so this brings us to even what work EMI does is we spend a lot of time with state agencies saying, this is how you can use your levers, right? You work directly. If you're a fully managed care state, then you could put it in your contracts with the managed care providers. We also work with MCOs directly and saying, you're going out and you're going to invest in a technology solution. Many of them are doing it right now. They're all, and again, so sometimes the MCOs go to the state and say, do you have a specific solution? Like, for example, the Aunt Bertha's, Unite Us, the NowPal, the social referral platforms. We have a cascade across the country. Like some states are top down, North Carolina as an example, Nehi, Nebraska, that they have said we're going to use one social referral platform. Well, then you have states like New York that they use everything, right? They have no direct, they can enforce the standards being used, the codes, but they're agnostic to the tools. So I think this is where the health plans work with the states and saying, can we make sure we invest in the right solutions? And you can incorporate or make the requirements for using standards-based in those agreements. So again, lots of opportunity. I always say it's not just only the federal top-down rules. USCDI is great, proposed SDoH data class. It was included in level 2, but not included for version 2. We're having ongoing discussions. But yes, that USCDI will be for certified technology. Not all the systems that we're talking about need to be certified. So that's where the states come in, the ones who actually procure or have the acquisition authority that can drive the standards adoption.
I think
any comments from Jocelyn or Pooja here?
Sorry, I'm going to dive in. I think this is a really important point about sort of levers and what levers are out there in the market, because I think that there are so many things to be done, right? It's not that people don't want to move all of these topics forward, but I think, to Evelyn's point, as soon as you get that guidance or that direction, and I would say almost like a finger on the scale or a thumb on the scale of sort of where ONC and the feds are headed, I think it's incredibly important to recognize that that moves and drives how organizations like the states are going to prioritize, or how commercial payers prioritize what they're doing, because it's a signal of sort of where the regulatory or policy work is going to head. It's really, there's a little bit of a catch-22, or I should say a lot of a catch-22 out there in the market today, right? That we hear people saying they don't want additional regulation, but then we see in a day-to-day basis in roadmap in many of these organizations that things can't get prioritized unless they're under reg. And so, this work that we're doing in the fire community and in these multi-stakeholder initiatives, I think is a really good sign of sort of the collaboration that can happen with the states and with the feds to say, how do we build things that are being driven by the commercial players, the providers and the payers and the vendors in the market, and where is it that the feds or the states can start to come and put those levers in place? Because you need some bolus of adoption, right, of people actually implementing for real to first mature the standards and make sure that what you're building is right, because nobody's going to get everything right from the get-go. But I also think just to show that this is the direction we're headed, the directionality, so that we can, I use the phrase skating towards the puck a lot in my day-to-day existence. And I think that, Gravity has been able to pull together this sort of community of individuals, right? To say not everybody's going to do it the same way. Everybody's going to sort of roll their own, and they all need their own on-ramps. But at least we can say we're going that way, and there's progress points that people can point to, whether they choose to be that very first person doing it, or they're going to be in the second pack, or they're going to wait until the stick comes out and somebody gives them a deadline to have to adopt. I think it's game changing in how the industry is working together, that we're seeing sort of the regulation so closely aligned with even draft standards at this point in time.
All right. So last major question here. We've talked about value-based and accountable care and all the additional information you want to collect about a patient or a member and what their needs are. How do we balance this with collecting and using all that data with concerns about consumer and patient privacy, the so-called data justice and unintended consequences? And Evelyn, Pooja, could you give us some thoughts about that?
Sure. So funny enough, Ken, that's my topic tomorrow at Health Data Palooza. So I can tee up. They'll be talking about, current concerns with individual privacy and security as we capture and share social determinants of health data. So I do want to say, from a data interoperability perspective, we must continue to remain vigilant. And I always say, just like there's an oath on we follow the physician oath, first we must do no harm, right? So in other words, we need to maintain privacy, security, and equity as we collect and share whole person data. So we, as we work with our very large communities to collect and share this data, we're creating these standards. We want to scale them. We want to have technologies that support this. It has to be done judiciously. And we are already seeing that, we don't, as more data collected, it does end up often further disadvantaging those that are already marginalized or socially excluded, right? So, we have feedback, they're concerned, if you start documenting their social risks, that they'll be judged, so it comes across, in various ways. So I think we still need to do a lot of more work. The Gravity Project did with our technical advisory committee. So I'll just put in a plug that we did publish data principles, because this is a really important issue for the project. It's really, how do you use this data in an ethical way? And again, you don't want to further exacerbate what we see in the market and have these individuals, again, they don't, if all of a sudden we start sharing them, but if consent, this is very much driven by consent, and the individual does not trust that their data is going to be used the same way, they're not going to let it, right? We want consent is primary. So we need to have more education, and we need to have more vigilance.
Pooja?
Yeah, I'll just add to that. I think, this is, even with the interoperability rules that we saw come out, we hadn't even seen anything around necessarily, the privacy and the security and the sharing of the data. There's frameworks out there, but nothing's definite. This SDoH stuff just adds a layer of complexity to that, right? And in my mind, I immediately go to, mental health stigma and how difficult it is, right? That's just a whole nother level of, you need to capture this information. How do you share it? What do you want to share? So I think it's just a complexity. It's something that's going to have to be worked work through. And it's good to hear that you guys put out the principles, because I think that's kind of a first step. But I think, this is going to be a big, not a barrier, but something that's going to have to be addressed. I mean, we know it has to be addressed, even just opening up our clinical and claims data, right? And, this just, again, adds that additional level of complexity. So a lot to be worked through as we go through the process of this.
Wow, we've covered a lot of ground here. Evelyn, as we're wrapping up, any final point that you'd like to bring up, an industry ask?
Sure. I'll put my plug in for Gravity pilots. So our roadmap, we have us starting the pilots in the summer once we publish the FIRE IG, but the pilots can actually start. So I'm actually raising funds for the pilots right now. So we do want to have a diversity of stakeholders or diversity of actors testing in the pilots. So we just want to put a plug in that, we cannot achieve the interoperability we are seeking if we don't have all the systems that are involved in capturing and sharing data to come to the table and test. As Jocelyn noted, we want to mature the standards. We can't do that if we don't test in the field. And of course, if we look at from a regulatory perspective, our agencies, ONC and CMS, do not want to make requirements unless they're fully vetted, right? So they're hesitant to that. So, so it's like, it is a catch-22. We want to make sure we have developed the right standards. We want to test them and have that feedback loop. So then, they can be part of future requirements.
All right. Any final comments? Jocelyn, Pooja?
Yeah, I want to add on to that, because it's funny because we're kind of facing the same thing with the consumer-facing implementation guide at the Care Alliance that we put out, the consumer-facing real-time benefit check. It's one thing that we're creating these things, but, making sure that people are able to test them and move these along. I used to be a product manager for an e-prescribing EHR company. And, we focused on what was required in regulation, right? And so our focus, our priorities was all about that. We knew all this other stuff was going on. It was on our list, but getting to that, it took regulation. So it really is a chicken and egg that, we want to move these things forward, but trying to make sure that we're balancing that. Can we be testing it with the right folks? Do they have the funds and the focus to bring the people to the table? It is a little bit of a struggle, but I just wanted to thank Evelyn. I've learned so much actually in this short time, and just so much to be thinking about. And I'm really excited about the work that you guys are doing. So thank you for joining us.
Thank you.
I'm going to start off and agree with Pooja. Generally, when we have guests on, I know most everything that they're talking about, right? Because I'm living and breathing it on a day-to-day basis. I love this. I get to hear the 10-minute version of Evelyn's updates all the time, and I never get to hear about the non-HL7 part of it. So it's been great to listen to all the work that you guys are doing. And I think, this is important to Pooja's point. I think that we are always in this catch-22 of people, figuring out how to secure the resources. And Ken, I would almost do a pitch to you to say, I think a common theme we're hearing from many of these different early, I think of it, we're at a staircase that's 2,000 steps tall, and some of us are on step number 1, and some of us are on step 2 or 3, but we're really at the very beginning of this journey. And I think this idea of how do we create the value proposition and the data that shows doing this work delivers value, delivers the outcomes that we really want to see, sort of maybe a conversation about metrics where we pull people in to really talk about how do you make a decision as an organization that this is the place you're going to go and spend your scarce resources to be able to participate. Because I don't think anyone would disagree that the work that Evelyn is doing is incredibly important. How do we make it easier for organizations to pick up their head and say, I want to solve the issues around patients understanding what their cost is. I want to understand how to make sure that my most at-risk patients get the services in the community that they need. I want to make sure that when we're using our resources to call patients, we're doing it for the patients that we think are most at risk in our portfolio from a practice perspective. I think that how we make it easier as an industry for people to shake their head and say, this is where we should be spending our money and our time by coming and participating, I think is a challenge for all of us as we look sort of coming out of COVID, right? All of the demands and then back to whatever the new normal looks like. How do we make sure that people are ready and able to get the resources from their orgs to come and contribute in a meaningful way and really drive us forward? So, and thank you, Evelyn. Great to see you.
Yeah. Okay, great. I want to thank my co-hosts, Pooja, Babbrah, and Jocelyn, Keegan, and especially to thank our distinguished guest, Evelyn Gallego of EMI Advisors and the Gravity Project. And thanks to our audience for listening to this edition of Point of Care Partners, The Dish on Health IT. Please follow us on Apple Podcasts, Spotify, or whatever platform you use to pick up your podcast. And if you prefer, you can also watch our podcast on our video channel. And remember, Health IT is a dish best served hot. Thank you, folks.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with fire accelerators? Email us at info@pocp.com to learn more about our new monitoring subscription service called the Interoperability Outlook.